everyone. So my topic is acute post-operative endophthalmitis. Endophthalmitis, as we all know, it's a most dreaded complication and serious one. We can say it's the worst nightmare for any surgeon operating. So endophthalmitis, it can occur after any cataract surgery, after any glaucoma surgery, post even SOR, post pterygium. So first thing, before diagnosing its endophthalmitis, we must think about the TAS as well. So distinguishing between TAS and endophthalmitis at day 1 after the surgery, it's difficult. But it's important due to the seriousness of the condition and the divergent treatment strategies, as both TAS and endophthalmitis both have the different treatment modalities. So as we know, TAS, it's an acute inflammatory reaction of the interior segment, or we can say it's the sterile post-operative endophthalmitis. While endophthalmitis, it is the inflammation of the inner coats of the eyeball and intraocular colonization of the infectious agents with exudation and intraocular fluids, that is vitreous and aqueous. Here I am going to discuss few cases which has been referred to us. The surgery has been done somewhere else. According to the surgeon, the surgery was uneventful, but when the patient has referred to us, there was a certain decrease in vision. Visual acuity decreased to hand movements close to face. There was severe pain, 3 to 4 cells in the AC, and plus there is a streak hypopyon in the interior chamber. This is the case 2. Again, there is a marked decrease in vision, to hand movements, marked corneal edema with DM folds, and also there is a exudates and fibrin in the pupillary area. Even the glow was very hazy. Similarly, the third case also have the same symptoms: marked corneal edema, severe pain, vision is finger counting, fibrin on the lens, and exudates in the interior chamber. And this case, this was even the PL-PR was doubtful. ACs were full of exudates, and in this case, even we thought what to do next. So in these patients, as they were referred to us, the intravitreal injection antibiotics, it has not been given. So we injected vancomycin and ceftazidime with dexamethasone and taken the tab for the gram staining and the KOH staining according to the protocol. Along with that, we put the patient on topical steroids, atropine, cycloplegics, and the oral steroid also. So the question is, if the exudates are disappearing and the vision is improving, then there is no need of vitrectomy. Diabetes, generally we avoid to put oral steroids. Intravitreal can be repeated after 48 hours. Amikacin and gentamicin, we generally not preferable because they can cause macular infarction. Here is a small video. So for every endophthalmitic cases, most of the patient, they have fibrin in the AC or exudates. So first thing which is important, remove the exudates from the interior chamber. Two side ports are made in the eye, and the fibrin is removed. Either the fibrin is removed with the cutter or can be also removed with the McPherson forceps. The thing is, we have to clear the interior chamber and see, so that only we can perform the vitrectomy. As you can see here, we have used the Simcoe cannula and the cutter to remove the exudates from the interior chamber. After that, we used to do a vitrectomy. 23 gauge cannulas, they have been put. As here, the exudates is very thick, the fibrin is very thick. Can see even it's very difficult to cut with the cutter also. But anyhow, we have to clear the interior chamber. Then only we can perform the nice vitrectomy. So when the interior chamber is cleared, 23 gauge cutter cannulas are put. one for the infusion, one for the light pipe and another for the cutter. If first thing when you put the cannula, you have to make sure that the cannula is in the cavity. If it is not there, remove it. Don't hesitate to put 6 mm cannula. Nicely, vitrectomy is done. We do vitrectomy. We don't go with the extent aggressive vitrectomy. We just do core vitrectomy and possible to a possible extent so that all the exudates can be removed and there is a nice glow from the vitreous. After doing the vitrectomy, we used to inject the intravitreal antibiotics. Intravitreal antibiotics to the patient. So, remove fibrin from anterior chamber either with the cutter or with the McPherson. If the wound is open, you have to suture the wound so that the eyeball is taut enough so that you can go behind. And as I mentioned, don't hesitate to put 6 mm cannula. Clear the vitreous as much as possible. We don't induce the PVD, no SOI in primary sitting, and we don't prefer to remove IOL. So this is the patient after 2 weeks of PPV, had a good clear cornea, clear vitreous, and patient had good vision. So the thing is, suspect. First thing we have to suspect that it's endophthalmitis or not. Then we have to react and we have to act so that we can we can have a good results of the patients. Thank you. So earlier signs, depending upon the patient, maybe patient is having the pain and there is an inflammation in the interior chamber.
I think any patient who is giving you unusual complaint from his house that he is having more than you expect the pain, and when you examine in per high power field, if you count cells more than 5 or 6, you must act immediately.
Yeah.
Sir का जो कहना है कि signs and symptoms more than what is normal.
Yeah.
Anything abnormal. See,
You
I want to
act.
share my experience after operating more than 1,000 cases. पहली चीज़ जो सर कह रहे हैं कि always err on the side of endophthalmitis. ज़रा सा भी आपको लगे कि reaction ज़्यादा है, unusual है, TAS बहुत easy है. TAS is anti-segment, endophthalmitis is posterior segment. You have all B scans. Always err on the side of endophthalmitis. Think it is endophthalmitis.
Yes.
And second thing, the message I wanted to give that is slightly against EV's study also. Go for early vitrectomy.
Yes.
कैसा भी endophthalmitis हो,
Yes.
आप vitrectomy कीजिए. You clear the muck. You get a lot of things for sample also. You can
Exactly.
give intravitreal. It works wonder. Don't wait. जो आप बोले ना wait करना है. Endophthalmitis a wait, observe, ये सब कुछ नहीं. And in rare cases, even we have given silicone oil. In P. acnes, many times you have to remove the bag also. Those are rare cases.
So I'm saying
But I
it's
agree, लेकिन
don't
हाँ आपने
react,
जो
yeah.
कहा, so these two messages just wanted to share with you. Thank you.
Okay, thank you.
Yes, so oral we don't prefer to start like in suppose the patient is having diabetic or we don't prefer to start, but yes, topical we start, but as the sample is concerned, yes, after that we will start that. Intravitreal, yes.
Sir, मतलब there are two school of thoughts. Rightly, one you tell unless you aren't sure कि it is fungal or not, you shouldn't give. लेकिन जैसे मैं देता हूँ, sir, under cover of antibiotic. ये इनका topic है acute post-operative.
post-op.
Generally, acute post-op is usually
It's
it is
usually
bacterial.
bacterial.
तो under cover of antibiotics you can give steroids. तो इसलिए मैं थोड़ा सा इनके agree कर रहा हूँ. But you are also right, sir. Thank you.
What's that?
Steroid.
The dose of steroid, it's depending on 1 milligram according to the weight. Same. No, sir, according to the weight we used to give.
So if a patient is not diabetic, it's always better to start oral steroids in every case of end-off. You should start with oral steroids if there's no contraindication. Regarding intravitreal, of course, fungal, if you're suspecting, then we do not. Otherwise, in bacterial, generally, if it's not a very virulent presentation, then you can always combine it with the intravitreal steroid.